of the presentation. So my name is Gul, or Dr. Gul. That's what I've been known among my colleagues and professionals, that I work with. So today we're going to talk about a very important topic that's very close to my heart and something I'm very passionate about. The interplay of nature and nurture in a traumatic brain injury, and what are the implications for children, adolescents, their developmental trajectory, and the legal practice. So we'll begin with the slides. So this is me. I hope I've met with some of you on the call, or some of the colleagues that previously I have worked with, or some of the solicitors that I have worked with in the past. So I work for the Midland Partnership University Hospital. It is somewhere in the Midland. I'm also the Associate Medical Director and Director of Medical Education for the Midland Partnership University Hospital. And I work for the Keele University as a honorary senior clinical lecturer. So as most of you on the call would know, the traumatic brain injury is the leading cause of disability in children and adolescents. But and we all know that, but the outcome varies significantly between two young people with seemingly similar injuries. So I've seen in my clinical practice that I'll be asked to do a report for the condition, causation, and prognosis. And the causation may be similar, or the condition may be different, and the prognosis may be different as well. So I think it's very important. To the purpose of today's presentation or today's lecture is to understand that interface between the biological and the environmental factor, which are crucial in the prognosis and the medical legal assessments. So the key take-home message for all of us: the injury severity alone doesn't determine the developmental trajectory and the outcome for children and adolescents that I work with. What is nature? So it is very interesting. Most of you would know that in the Chinese culture and in the Korean culture, the age of a child doesn't start at the point of birth. They have only recently changed it. You'll be surprised if you don't know. They've only changed it in 2022 or 2023. So in the Korean culture, or the Korean system, so the child at birth is already 1 year old. So in medical practice, the work that I do with young people, mostly with neurodevelopmental condition, our understanding is that the age of a child, or all of the factors that start at the point of conception, or sometime a couple of months before the point of conception, because all those factors, the pre-birth factors, will have a significant outcome on the developmental trajectory of a child. So some of those factors will be when we ask about the pregnancy, was it planned or unplanned? So even when the pregnancy unplanned and the parents are excited to have the child, the two pregnancies will still have slightly different outcome, because whenever a mother find out, if it is unplanned, let's think about someone, a mother who has an unplanned pregnancy, socially doing well, economically doing well, a well-to-do family with no disadvantage or social disadvantage. But this mom has had some plans into the future, like she might have booked a holidays, she might be going for an interview in about a few months' time, or there is a career promotion or something very, very important. So although the couple have been longing to have a child, but because this did come as a surprise for them, so there will be cortisol rush through the mother body, which is interesting. Or they wanted to have a child, but they didn't expect the child to be arriving just before Christmas, or maybe when they would be going on holidays next year in summer, and the due date would be just somewhere before their departure for the summer break. Okay, so the outcome for this child will be slightly different than the outcome for other children who have had planned, but with a similar socio-economic or the environmental factors. So that's at the point of conception. Now, at the point of conception, if mother is stressed, at the point of conception, we're talking about the first few years. As you can see, the child brain begin to develop in the first 25 days, and then 35 days. The process carry on beyond birth. So as you would see later on the slide, the brain, some part of the brain continue to develop until mid-20s, especially the frontal lobe, which is more to do with executive functioning, social adjustment, cognitive function, interpersonal skills, judgment, those sort of things, and amygdala, which has a very important role when it comes to for us to think about young people with ADHD and what will be their developmental trajectory past mid 20s if they've had been diagnosed with ADHD at the age of 13 and 14 because of the primary ADHD, which we call the developmental ADHD, or because of the secondary ADHD, which could be because of secondary injuries or traumatic brain injuries just after birth with no pre-birth factors, or may have occurred at the point of when the child is 3 to 4 years old. So these are the developmental factors, pre-birth factors I'm referring to. Now we know that the cerebral palsy, when there is a disruption to the brain development and the child is born with this cerebral palsy, some of these changes or some of these traumatic injury may have had occur before birth. Okay, so these are some of the factors I want you to think about, what could be the possible factors that will have implication on the developmental trajectory for a child. Then the maternal factors. So we spoke about some of the factors that will be beyond mother control, but there are some maternal factors that will be asking mom when I'll see them for a medical legal assessment. If the mother has had been smoking tobacco, drinking alcohol, because these all will have implications for the brain development of a child before birth. Or even if the mother has had been taking prescribed or over-the-counter medication. If some of have had you seen my reports or my assessment, you'll always see that question that the mother deny or mother has had been smoking tobacco or drinking alcohol in the first 6 weeks, in the preceding 3 months, or in the last 3 months, and what will be the implication for that in the outcome for the outcome of that particular young person that will be working toward. Now, there is some in terms of the knowledge about the prescribed or the counter medication, because different prescribed medication will have different implication for the developmental outcome for a child. But the most commonly medicine that will be taken by most of the mothers is paracetamol. And there is some evidence if the mother has had been taking more than usual, even paracetamol, it has implication for the developmental brain or the developmental outcome of a child. So these are some of the prescribed or the counter medication. But then the intra-uterine exposure, we know that if the mother would have caught up in infection before, but like a cytomegalovirus, some other infections, these infections even before birth will have implication for the child outcome or developmental outcome. So these are some of the in utero exposure, but then the psychological well-being of a mother. It's very important that when we assess children, we think about the world around the child even before birth. The most important person in that world will be the mother. So the psychological well-being of a mother is very, very important. There are quite a few studies that were done just after the aftermath of September 11. There is a study that I can think of, which was done in Oklahoma or in one of the cities in the United States, where the mother has had watched the September 11 tragedy on the TV. So the developmental outcome for some of those children that were born to these mothers were quite unique to compare to the mother who has not had similar exposure to the September 11 event. So this is quite important. Now, the biological factor, if mom is hypertensive or mom has got thyroid and thyroid conditions poorly managed. So we'll have to think about all these things around that will have implication for the child. So if you have a child that you would like one of us to make comment on the developmental trajectory, I'll be looking to all those pre-birth factors, the biological, psychological, and even social as well. Now, the next thing is for me to start thinking about the genetic predisposition. Excuse me. Just like, we all have genetic predisposition to different conditions, from cardiovascular to metabolic condition to even dementia. So young people will have predisposition for some of those conditions that you can see on the slide. Attention deficit hyperactive disorder, what we call the primary ADHD or developmental ADHD. Then there is ASD, autism spectrum disorder. So this is the developmental ASD or the primary ASD, but you could have social and communication difficulties secondary to traumatic brain injury because of sensory impairment, because of the eyesight impairment, because of the hearing loss. These all can cause social and communication difficulties. And then the mental health problem. So we know that if somebody having a family member with severe mental health problem or schizophrenia, the risk will be high for the children born to those parents, for the mental health disorder. Then again, if one of the parent has had a predisposition for learning disability, my apologies, so the child is more likely to be at risk of cognitive impairment. So I'll be thinking about all those genetic predisposition when assessing a child for developmental outcome, for condition, prognosis, and causation. So this is the nature. Okay. Now, what is the nurture? So before I go into the nurture part of my presentation, so there was a study that was done a long time ago. So what happened? So there were two children born to the same mother, like a twin, babies. So, and one of the child was adopted by a very, very functional family. So parents or both parents were, or one of the parents were paranoid schizophrenic. That's quite an old study, maybe something that I was taught in the medical school that I'm quoting. Now, for the two children, twin children born to the parents with a high risk of paranoid schizophrenia. So one of the child was adopted by a family who was not very much functional, or the family who has had several social disadvantages. And the other child was fortunately adopted by a very functional family, with a lot of positive socioeconomic status, education, access to healthcare. So even the outcome for the two children were found to be different. The one who has had several further advanced childhood experiences went on to develop paranoid schizophrenia. The other child who was adopted by a very functional family went on to develop some schizoid personality traits, but relatively did well compared to his twin sibling. So that's why the role of environmental factor is very, very important in all medical conditions, but more specifically in traumatic brain injury. Now, what is nurture? So family environment where we are living in, like, the house that I'm living, the socioeconomic status of a child or the family background, the education or the educational background of the parents, that does make a difference in the upbringing of a child. Access to healthcare and rehabilitation. Now, one of the things colleagues ask about, or sometimes the parents ask me in my clinic, is it the quantity of time that you spend with your children is important or the quality? So naturally, we know that working class families have less time to spend with their children, but the time they spend is very qualitative, very good. But then, unfortunately, it's very sad. A lot of young people who are born in a disadvantaged background, so they could see their parents hanging around all of the time because they don't have access to work, or because of their mental health condition, because of their own disabilities, or there is no job. So they pretty much see their parents all around for most part of the day. But their children, other than in exceptional circumstances, are less likely to do well if they don't have support from the external system like school, or if they got a mentor outside home, or they got a role model outside home. So it will make a difference. Now, the other thing is that we're talking about a child that is born born with a predisposing factor, and then has good environmental factors. So the outcome for that child will be different than the outcome for a child who was born with predisposing genetic predisposition to develop some of those conditions that we've spoken about, but then that child goes on to develop or experience adverse childhood life events, what we call the significant life event. So now you could start thinking about, like, what will be the outcome for a child A, and why the outcome for the child B born to the similar genetic predisposition will be different, because of the family environment, because of the socioeconomic status, because of the access to education, access to healthcare and rehabilitation, and access to support system, or the healthcare system, or adverse childhood experiences will make a difference in their developmental outcome. Now, we know that, as I just mentioned earlier on, colleagues, that the childhood brain continue to develop into the mid 20s. There's a lot of research that the brain doesn't stop growing until mid 20s. But the frontal lobe, which developed the latest, matters a lot. And we all know that if there is a child with a frontal lobe brain injury, whether it was because of the frontal lobe tumor that I have had seen a child with, and or there was a child with a traumatic road traffic accident that has led into a frontal lobe injury. So the executive impairment will be evident. The emotional dysregulation will be quite unique. They will have challenges with planning and organization, and struggle with social adjustment or social interaction. Now, one of the things that's very, very important for all of us to know, that the child might have had an accident at the age of 4, will have an access to the support, and there was a lot of support, everything was going well. Now, suddenly, unfortunately, some of those support systems begin to withdraw at the age of 18. And unfortunately, beginning to see some of those challenges develop beyond the age of 18. And that's what we call, the child beginning to grow into the deficit, which can emerge years after the injury. So it's not that, the age that we have been asked to see a child at the age of 4, and then asked to see for another review at the age of 12. And more often we'll be asked to have another review at the age of 18. But I would recommend there should be another review at the age of 21 and 22 to begin to rethink about the developmental outcome for that particular young person beyond mid 20s. Now, I briefly touch upon this slide in my previous discussion, the interaction between nature and nurture. So think about two 13-year-old who have had sustained similar moderate traumatic brain injury. So I'm talking about patient that I had seen in the last 10 years. So if you look into their neuroimaging, if you look into their neurology report, pretty much same injuries, or pretty much like the same developmental outcome as far as the neurology opinion was concerned. But then one child would go on to have strong family support, good school, EHCP, early rehabilitation, and positive environment or access to the services. But the other child now has had prior ADHD, which could have been undiagnosed. So maybe the child has had a road traffic accident at the age of 5 or 6, but growing on to develop ADHD at the age of 7. So there were, or may have already been diagnosed with ADHD by some of the clinicians can go on to develop, to diagnose ADHD at the age of 4 and 5. But then you could have a primary ADHD, but you could have secondary ADHD because of the traumatic brain injury, or because of the injury to the brain. But then you'll have to think about, between the two young people, what were the prenatal maternal factors that could have put this child at high risk of developing XYZ condition, and what will be the implication for prognosis in the long term or as well as in the short term. What had been the adverse childhood experiences before the traumatic brain injury or the road traffic accident, and what has had been the experience of a child after the road traffic accident. So I could think of a child who has had a road traffic accident, but then went on to have many adverse childhood experiences at school, at home, loss of a family member, like, the separation of parents. Can you see that, like, with a similar moderate traumatic brain injury, the two children will have different outcome than the family stress, and again, like access to rehabilitation. So unfortunately, children would be very close to the main tertiary care hospital like Manchester, Birmingham, or Edinburgh will have excellent access to rehabilitation support. But if somebody is in the middle of nowhere, like Middlesbrough, Hull, or Northumbria, or maybe in the Peak District, will have limited access to tertiary support services. Now, so for what we have been discussing so far, the interface of nature and nurture, it's very important to understand while there is a blessing or in disguise that the children brains are resilient. So if somebody has had an injury at the 40, which will be different than if somebody has had injury at the age of 4, because the outcome will be different. The child brain undergo a regular development. There is a lot of myelination. There are a lot of changes. So that makes the impact of that injury very complex and evolving. Let's say the child has had a brain injury at the age of 9 months. It will have implication for this speech, motor milestones. But if the child has had a similar injury at the age of 7 to the same part of the brain, the outcome will be different. Now you can see that why the outcome will be different, because some part of the brain would have already had developed, like the speech skills, the motor milestone, or the sensory, the fine motor skill would have already been developed, and the toilet training, those sort of things, has had developed by now. Now we have spoken about the causes and symptom of pediatric traumatic brain injury. We've spoken about, you can have a traumatic brain injury before birth, but then most of the cases that we'll be working together on will be not less likely the one to do with the before birth, but more to do with at birth, because there may be a negligence at the point of birth. There may be poor clinical care that was offered at the point of birth. You could think of many clinical examples. I would rather not go into the legal case scenario, but the clinical example. Let's say a child is born and his bilirubin level is quite high, okay, or he didn't get enough oxygen, or his Apgar score was quite low. So this child is likely to have an assault or insult to the brain at birth, or a mother had contracted an infection, and the child passed on that infection to the child because of the poor clinical care, or because of other predisposing factor, like mom was diabetic or mom was already septicemic. So these will be passed on to the children, and these infectious disease could go on to develop meningitis at birth, encephalitis, or different infections. Now that is at birth. Now the child is still growing, as we know, until he's 21 or she's 21. So there are different formative developmental stages. So if the child is being hit by a car at the age of 4, frontal lobe. So the frontal lobe hasn't yet developed, as we can see that, develop until your mid-20s. So this child beginning to have cognitive impairment, tiredness. You could see that, he's getting tired. He's beginning to fall back at school. He's not like what he looked like when he went to the nursery at the age of 3. He was active. Now he has slowed down significantly. Now, what are the potential consequences? When you ask me for a report, so the condition, the causation, and the prognosis, and the developmental outcome. So the potential consequences for a child is social difficulties. This child is more likely to go on to develop social difficulties, will have communication challenges, will have learning impairment, and likely to develop mental health problem or emotional health difficulties, okay, and behavioral issues as well. There is a question that, if the child at the age of 2 can have PTSD. Yes, it is not in the DSM-5 criteria, but there are some case studies that the child could have PTSD as young as at the age of 2, but there is a DSM-5 criteria for the post-traumatic stress disorder in a preschool children, which is a slightly different criteria than what we would use for the adults. But there is a lot of similarities, but you need an expert to approach from the child perspective rather than what you'd be looking for in adult PTSD. So, as I said earlier, on some aspect of the traumatic brain injury emerge later because the children will miss key developmental stages. So I've spoken about the language, fine motor skill, gross motor skill, toilet training, and that will have implication with this different aspect of their life, socially, academically, and it will have impact on the family as well. So the nurture and the nature interaction, it's like it doesn't stop at the point of birth. It continues to evolve until the child is into mid-20s. So the environmental factors are very, very important. Now, in terms of the environmental factor, if I bring your attention to the like somebody, I'll give you an example of myself. I got a very strong family history of diabetes and cardiovascular condition. So that is genetic, that is predisposed. So now it's all depend upon my lifestyle, how likely I can develop some of those conditions and how I can modify some of those risk factors. How do you modify, risk to develop cardiovascular condition or diabetes mellitus? Exercise, healthy lifestyle. So you're beginning to modify some of the risk factors. Now, there is another person who has not had as severe history or predisposing genetic predisposition to cardiovascular condition or diabetes like myself, but he has a poor lifestyle. So this person is now more likely to develop cardiovascular condition than myself because if I have changed my lifestyle to modify some of those genetic factors or predisposition. So I think that's very important when we talk about children with traumatic brain injury. So the injury has had occurred. Now you cannot do anything about it. What you can do, you beginning to modify some of those environmental factors to have a positive outcome for that particular child. I think it's not a science, but it's like it is a common knowledge that the childhood brain plasticity enable adoption and recovery. But again, if I was to repeat myself, it increases the vulnerability during the critical developmental period. Again, the severity type and the location of brain injury determine the cognitive and emotional recovery outcome in young people. And the genetic and the pre-injury factors that we've spoken about influence the recovery journey or the developmental trajectories after the brain injury. And the take-home message will be this dynamic interaction with the environment. So the biological factor interact with environmental factors to shape the post-injury recovery, functioning, and the developmental outcome for that particular child or young person. Now, a few lines about the family, the socioeconomic context. So we know for a fact that impact of a positive family environment will have implication on recovery journey. We know the socioeconomic status of a family. I've got a child under my care who was adopted but has come from a very disadvantaged family background with a lot of genetic predisposition to develop some of the neurodevelopmental condition, and he has been diagnosed with ADHD, but he's adopted by a very, very lovely family that I have a lot of respect for them. So this child is doing extremely extremely well. So his predicted grades in the GCSE is all A+. And there is a lot of motivation support comes from the family. The last when I met them before GCSE exam, the mother said he has been promised that if he gets A in a particular subject, so mother is going to give him £500 for every A grade. And the grandmother, sound like quite with a good heart, has promised that if he gets A grade in a particular subject, he'll get £1,000 for each A grade. So if he gets 9 A grades in the GCSE, he's going to get 9,000 and then 5,000 from his mother. So can you see like the environmental factors are beginning to play or modify some of his genetic predisposition of this particular young person. Now again, the education environment, this child that I'm referring into, under my care somewhere in the country, goes to private school, has a lot of support. Mom is quite highly educated, very highly educated. He goes to a private school. He's a lot of support, but I'm sure he must have had input from a lot of profession in the past. After being adopted by this family, so and there must have been a lot of support which was quite family centered and available both at home as well as at school. Now, all of those factors that you can see on the slide will have an impact on the developmental outcome. Okay, sometimes when I see these young people, when I see reports that has been shared by my colleagues, either for the defense or for the examined, it doesn't address the systemic issues around the child, and sometimes doesn't make the recommendation that uh, what is to be offered to the family as a unit. So, if you have had work with me, you would see that it's very important for me to make systemic intervention recommendation for the whole family, because sometimes when we have had these young people who had come to us after traumatic brain injury, second road traffic accident, because the mom focus is on the immediate need of a child, which is physical health, and it has implication for every other member of the family. Sometime we got two children. One has had severe traumatic brain injury, quite disabled, and the other one that I'll be asked to do a report. Then you'll have to think about, like, there are a lot of literature available. What will be the implication on a child if there is a sibling in the family home who's quite disabled for XYZ reason? And what are the developmental outcome for a child? Is there is a mother, because of the same accident or similar challenges, is struggling with mental health problem, PTSD, postnatal depression, even like has had a child, the child that we've been working on, or that there is a different child with, and the mother developed PND, postnatal depression. So it is very important when we ever make recommendation. These recommendations need to be individually tailored to the child and the other the environment around the child. Whether that means additional support at school, that means additional support to the mother or father, or additional support to the sibling as well in that household. Now, I think I've already spoken about the diabetes and cardiovascular conditions. So the dynamic nature and nurture interaction continuously shape and reshape each other in the pediatric brain injury recovery. The child difficulties and the environmental response to those difficulties influence each other through ongoing feedback loops, which affect the outcome. I'll give you an example. So the child has social communication difficulties. Okay. And mother is quite distressed because of the child's social communication difficulties or cognitive difficulties. That unfortunately, sometimes even the mother doesn't wish to reply back in a way that could develop attachment difficulties or could have negative developmental outcome for a child. Let's say John, who has special mental health, social communication or learning needs, and the mother is not sleeping well. So mother is quite distressed. Mother doesn't get the support she needs. So what will be the interaction between John and his mother, who's also distressed? So can you see the two factors influence each other through that ongoing feedback loop and will affect the outcome. So if the mother gets the support, then there are different outcomes for the child. So it's very important that we keep in mind, like, what will be those interface that will have important implication for the child, our developmental outcome or the developmental trajectory. Now we know for a fact that the injury timing affect different developmental domain, so that required long-term monitoring and adaptive support. So what is important for all of us that we have a holistic assessment. So I did a report for one of the child, and that was many years ago, and this solicitor came back to me and said that it sounds like I've done a chapter on the family history, because my family history went on to 15-20 pages, but because that was part of the holistic assessment, because that best described the need of a child, that best described the developmental outcome for that particular child, considering the genetic predisposition that this child was born, as well as the environment that he was being raised with. Now, what are the key legal questions for all of us on this call? So what are the specific deficits that can be attributed to that traumatic brain injury? But what are the roles the pre-existing factors play into and have an implication for the long-term developmental trajectory, condition, prognosis? We're not talking about causation, like, now we're talking about the condition prognosis for two children with similar traumatic brain injury. And there is a question about the quantum, like often the risk of mental health problem. I believe PTSD is quite unrecognized in the medical legal assessment, especially in the traumatic brain injury, because the focus is quite often on the physical health morbidities or the physical health difficulties. So as I mentioned earlier on, the child is likely to develop depression, anxiety. This child is more likely to develop depression, anxiety because any person with a brain injury is at 40% elevated high risk of developing mental health disorder. But then the question is that uh, was John struggle or did John struggle with PTSD symptom uh, when he was 3 years old, when the injury was at 2.5 year old? Yes, you could have a child, you could have a person with PTSD symptom at the age of 4, but it need a very in-depth assessment by an expert. Like, what was the child like in the first few weeks? Irritability, crying, sleeping with mom, regression. So there is a child that I'd seen some time ago. So the child was by now 6 or 7 years old. He went back to his mother's room, start bedwetting, crying, waking up in the middle of night. So you can see all that, like, changes that could be explained in the context of post-traumatic stress disorder in a child. Now, we've spoken about the nature and nurture interaction. As I said, the social environmental factor can buffer the injury factor, and the adverse environmental factor can worsen the outcome. So you could have the same injury for John and Sarah, but you could have different outcome for both of them, which is quite important to understand. Now, the causation complexity, often the cause A, the cause B, the cause C. Now, if you look into all the slide that I have had shared with you in the last half an hour, multiple contributing factors, both in the nature and the nurture. So that's why you need an expert neuropsychiatric opinion who fully understand the developmental predisposition before birth, at the point of conception, sometime before birth. The one thing I've not spoken about, the domestic violence. So the child is born with no birth pre-injury or pre-birth risk factor, but the mother has now been exposed to domestic violence. So this is more. So can you see the outcome for this child will be very different? All the injuries were similar. So it's very important to distinguish the injury factor versus what had been the background risk factors. Now, the prognosis is very important, for everything that we do for the honorable court. So what will be the prognosis for two different children with similar injuries? So some of the children, as we said, that you can have, they grow into the deficit, what we call the sleeper effect. So the long-term monitoring is required, and the educational and occupational impact evolve. So you cannot say for sure, with certainty, what will be the educational and occupational impact for child before GCSE, before some of those education qualification, and before you develop some of those adult life independent skills, like you cannot comment what additional support this person would require beyond 18th birthday. Now, the quantum consideration is quite important. What has been the cognitive impairment? Two children with similar injuries, one with a cognitive impairment, one without cognitive impairment, will have different quantum consideration. Similar injuries, but different behavioral outcome or dysregulation. What are the care needs and what is the impact on a family? So you could have two parents, but then you could have a single parent with a child with similar injuries. So you probably will have to think about what has been implication for a single parent and what could be different for two children with similar injuries if they would be living with the same single parent or both parents. And what will be the education and employment impact, not only for the child but other sibling as well as the parents as well. Now, I'm sure you're familiar to this term, the biopsychosocial. So it's very important whenever we arrive, when we write the formulation as a pediatric neurodevelopmental psychiatrist. So I'll be taking into account the biological risk factors, the predisposing, maintaining, perpetuating, and protective factors. So you could have children with more protective factor but less predisposing factors. So this is good. But then you could have children with a few predisposing factors but no protective factors. It will have different implication for two different children. And we should always consider the 5P model. Now, what are the take-home messages today for us? The outcome after pediatric traumatic brain injury not determined by the injury severity alone or by the location. Some deficit emerged years later. Understanding this interaction is essential for a comprehensive medical legal assessment. Rehabilitation and family support can significantly alter the outcome. It's very important that we continue to think about that the nature and nurture interact continuously and shape or modify different risk factors. Thanks, and I'll be happy to take any question, Kate, now.
Thank you so much, Dr. Gill. That was really fascinating. Would you mind just stopping sharing so we can see your face? And then, yeah, we've had a couple of questions. So I'll start with the first one. If a young child was born very prematurely and so at risk from developmental issues, but wasn't diagnosed with any issues, then had an accident leading to TBI and ADHD symptoms, is there a way of identifying whether it's primary or secondary ADHD?
That's a very, very good question. So because the child was born, so you could say this child was likely to develop ADHD, the primary ADHD, but now the exacerbation of symptom would be different. So if we're talking about two children with similar birth factors or pre-birth factors, the outcome for the other one will be different than the one who just had early birth or was born at the age of 27 weeks or 30 weeks. But the medical sciences has improved so significantly. A lot of these children would go on to develop and have a positive outcome. But this is one factor. The other factor that we'll have to take into consideration the impact of the environment. So John was born with a pre-birth, like at 28 weeks, 30 weeks. But then he was born into a very supportive environment. So the outcome will be different for John than James, who was born with a similar pre-birth factors, but then born into a very disadvantaged socioeconomic or disadvantaged family background. But then you can say that, this child, this is I have seen a child. This is a question that I'd seen a child that I would say that was likely to develop, but the severity of the symptom would have less likely to be as bad as it is now because of the traumatic brain injury.
Lovely, thank you. Someone else has asked, what are your thoughts on the emerging data looking at increased likelihood of developing ASD in children who sustain TBI?
Okay, again, you'll have to go back to the basics, like taking a very, very good family history is very, very important because the genetic linkage for these conditions is very, very strong. Okay, as I said during the webinar, that you could have social and communication difficulties secondary to traumatic brain injury, but doesn't necessarily mean that it is ASD or primary or autism spectrum condition. So, but in all cases, you could say that you need to get a very good history from the parents. So, the simple question that I ask the parents: are you introvert or extrovert? What your partner thinks about you? How people know you around in your workplace, and how tell me about what were you like in the high school? How many friends you have? You try to develop a case that this child was more likely to develop ASD or not likely to develop ASD because both parents are quite social, they're outgoing, nobody in the family or in the first cousin or in the sibling had been diagnosed with ASD or ADHD. So this child was less likely to develop social communication difficulties, but the social communication difficulty the child present now is secondary to traumatic brain injury.
Understood. What is an appropriate age to diagnose dysexecutive syndrome in a child who has sustained a TBI?
For the risk assessment that we ask our neuropsychologists, most of the neuropsychologists wouldn't undertake a neuropsychology assessment before the age of 7. So the risk assessment that we do is recommended after the age of 7. Some of the psychologists might do some component of the risk assessment to measure or to establish the cognitive impairment before the age of 7. But for a comprehensive evidence-based report that I would do or present to the court will be after age of 7.
Lovely, thank you. 2 more questions. This from Aisha. If a child has a traumatic brain injury before they have a fully developed frontal lobe, how likely is it that executive skills and independent living skills can develop with rehab if rehab didn't start until that child was in their early 20s?
So can you repeat the question? So the child
Yeah.
is, what was
So
the age of the
if
child when he developed the brain injury?
before they've fully developed their frontal lobe, she doesn't give a specific age. She just said if the child has a brain injury before fully developing their frontal lobe,
Okay.
how likely is it that their skills of executive and independent living skills can develop with rehab if the rehab didn't start till they were then in their 20s?
Well, depend upon like, okay, so you just have to go one step back, like,
Hmm.
so what the child was capable to do before the brain injury. Okay, so you got some sort of benchmark, and then what has had happened since the brain injury and the impact on the executive functioning. So in terms of the depend upon like severity of the brain, the frontal lobe injury. If the frontal lobe is severely injured, so pretty much, what we call the frontal lobe injury, severe frontal lobe. So there isn't much you can do, but other than like the physical aspect of their day-to-day function, because there will be always that compromise of the cognitive function or executive function.
Lovely, thank you. I had one of the questions in chat I'm just going to come to. So, if a child grows up in a bilingual house, does that impede their therapy potential? As in, the therapy will be in English, but at home the family may speak the parental language.
That's a very interesting question because I'm in a similar situation myself. Like my children are bilingual, so and I could see that concerns were raised by the nursery, and they were more likely to make a reference to the speech and language therapist. But by I think with the passage of time, they all likely to pick up linguistic skill. The kids are very intelligent. Like the kids can learn more than one language at a time. I see a lot of families from London, like they speak Russian at home, they speak Chinese at home. Other than the family that I see from the South Asian background, and we all know for a fact that they go on to develop and do very well at uni at a postgraduate level. Like so I wouldn't say that bilingual is a compromise. Sometimes being bilingual with an extra strength, or I think you think about like the brain is functioning like at a slightly higher level, or being trained to function at a slightly higher level than if the child is not bilingual. So what I'm trying to say that we know for a fact these children would go on to develop, go on to uni, and go on to different professions like legal, medical, or science, become scientists.
Really interesting. Okay, so if a child at the age of 6 months had a serious frontal lobe injury and lived in a healthy family environment, and then at school they were described as average, he's now 16 and a half. Would you recommend that he should be examined when he reaches 18 or 20 before like considering a final settlement?
Okay. Yes, definitely. The because your long-term life outcomes for all of us will be like, what were my grades in the GCSE, other than the physical skills. What were my grades in the A level? Like what is the education background of my family? So there is some linkage that we have had discussed. Now, definitely need to be assessed by A level, so you can see that where the child is heading toward. It's not only to establish the developmental outcome, but look into the support system as well. I got a child under my care that I have had been involved since she was 11, but she's somewhere now in the Europe at one of the university. So it's just following that care package as well is quite important. Just to answer your question, it will be quite important, as I said, the child should be assessed at the age of 18 and should be assessed by the same clinician at the age of 21. When I say by the same clinician age of 21, because if the child get to be seen by an adult psychiatrist, their perspective might be slightly different from a developmental perspective than what we have been trained, what will be the implication on the developmental outcome for that particular person.
Fantastic, thank you. One final question, Dr. Gull. If treating a child with PTSD, should the family all have therapy too to support their issues to lessen their emotional impact on the child?
So if the PTSD, just say again, the PTSD.
So if you were treating a child with PTSD, do you think that the family should have therapy too so they can better support their own
Of
child?
course, of course, Kate. I think I've mentioned that. So if I've done one of report for yourself or some of the colleagues on the call, you could see that there isn't a single report that I've done without recommendation for the family. I would always make recommendation for the family, because let's not forget about, like, I wish if I would have put a slide that I used to do for the medical students at Imperial. So I put the child at the center, then the family, that's the next circle, then the school, then the neighborhood, then the country, then the world. All these factors will have implication for the child. So if you make a recommendation for the child, but if you don't make a recommendation for the parents living 24/7 with a child, it's just like, you're flying on an aeroplane, and you miss the instruction, which was that if there is going to be turbulence in the air, so making sure that you put the oxygen mask first before you put your child. So if you don't put the oxygen mask to yourself first, if I don't make recommendation for the family, so can you see that, everybody is focused on the child, and sometimes we would make the recommendation for the mother, but we forget about the father. I remember there was a very interesting leaflet at Hillingdon Hospital that I used to work, which was specifically designed for the father. So you don't say only for the mother, you say for the father as well as for the sibling as well. So there are different type of family therapy that we recommend, systemic, structure. So I think it's not a structure, because you don't recommend any structural readjustment within a family or the power dynamics. You're addressing the systemic issues. So as I was trying to say that, if the child, let's see, a child has become very cranky and irritable and then sleepless night. So what is the implication for the mother? And what would be the response of that mother looking after herself, other sibling, especially if that mother was going to work every day, 5 days a week? So ignoring any therapeutic support for the mother, I think probably it's unethical. I don't want to use the word criminal, because you're all solicitor. It is my professional opinion that, I've not done a single report in my career that I've not made a recommendation for the support for the family, because you cannot make a difference in a child life. A lot of the therapy that we offer in children's services, we offer to the parents. So the parents will be part of the therapy. So you can't just ignore or take the parents out of the equation. Parents is one thing. Sometimes you have to go into the school and provide that psychoeducation to the school about the need of a child. So that's, you start thinking about this, sibling, your family, depending upon, it may be grandparents also you need to involve, because they're part of the family. And then the school is also, because that's part, because most of the time the child will spend at school. If the school doesn't have understanding of his needs and how to address some of those emotions, so you're maintaining maintaining the illness by not fully understanding the problem.
Yeah, that's fascinating. Yeah, I like the analogy about putting your own oxygen mask on so you can
Absolutely, yeah.
help your child. Yeah. Dr.
Yeah.
Gul, thank you so much. I've certainly learned a
Welcome.
lot, and I'm sure everybody else has. So we've
Yeah.
come to the end of the questions. Just to remind everybody, this has been recorded, so I will publish this on our website and share it with everybody who registered so everyone can watch again. If anyone has any other questions, please do email NRC. We'll pass those on to Dr. Gul. But thank you again, Dr. Gul.
No, have a good day. Thank you.
Thank
Bye.
you,
Bye.
everybody.
Bye. Bye.
Bye.